Good morning and welcome to the First Coast Black Nurses Association Cancer, Colorectal Cancer Dialogue. My name is Jocelyn Turner. I am pleased to be your moderator this morning. You are going to hear two amazing speakers. One is Dr. RENARD RAWLS, a local gastroenterologist here in Jacksonville, Florida, as well as Mrs. GWENDOLYN BRYANT, as she tells her impassioned story about her daughter, Tiffany. Today's program is a collaboration of the First Coast Black Nurses Association and the Northeast Florida Medical Society with sponsorship by United Healthcare. We are so pleased to have you join us this morning. And don't forget, for those of you who are requesting CEUs, that you complete the evaluation at the end of the program. Again, I'm Jocelyn Turner. I am pleased to be your moderator this morning in the absence of the president of the First Coast Black Nurses Association, Dr. Carol Neal. So at this time, I would like to introduce you to Dr. RENARD RAWLS. Dr. RAWLS is a gastroenterologist with the Borland-Groover Group. He has extensive research and experience here in Jacksonville, Florida, with Borland-Groover at St. Vincent's Riverside. Dr. RAWLS is a graduate of the Morehouse School of Medicine. He is from Fort Lauderdale, Florida, married with children, and again has done extensive work. Good morning, Dr. RAWLS.
Good morning. Good morning. First, I'd like to thank Mrs. Turner for that gracious introduction. Also like to thank the First Coast Black Nurses Association for inviting me to talk today. And last but not least, I want to thank each and every one of you for taking time out of your busy schedules to discuss a very, very important topic. So let's jump right into it. The first slide. Okay. All right, here's a quick overview of the talk today. Today we will discuss what is colorectal cancer, how does colorectal cancer develop, who is at risk for colorectal cancer, what are the symptoms of colorectal cancer, how do I prevent colorectal cancer, and if I have colorectal cancer, what are my treatment options? Next slide. Colorectal cancer is the abnormal growth of cancer cells in the lower digestive tract. Next slide. And the digestive tract is basically one long tubular structure which begins at the mouth and ends at the anus. And the final 5 to 6 feet of the digestive tract is called the colon or large intestines. Next slide. Now, the main function of the colon is mainly a storage organ. It stores stool until time of elimination. We do get some reabsorption of water, minerals, and electrolytes, but its main function is a storage organ. And if we look here on the right side, it's divided into different sections. We have the cecum, the ascending colon, the transverse colon, the descending colon, sigmoid colon, rectum, and the anus, where stool is eliminated. Next slide. And here we have a normal, healthy colon with a nice smooth lining. Next slide. And here we have an abnormal colon with the cancerous mass. Next slide. Now, how does colorectal cancer develop? Most cases begin as polyps or small precancerous growths on the wall of the colon or rectum. And after a period of time, sometimes 10 years, sometimes 12 years, sometimes 15 years, but it's a slow growing process, but these polyps can grow and develop into colorectal cancer. Some polyps develop from genetic factors. So if there's a family history of polyps, then it puts us at an increased risk of developing polyps in the future. And some polyps develop from environmental factors. You know, such as a high-fat diet. 40 to 50% of the Western diet is made up of fat. Also, a low-fiber diet. You know, we want to make sure we take in at least 25 to 30 grams of fiber a day, at least. And there are other factors that may be involved. Increased red meat intake, obesity, also patients with a family history of colorectal cancer are at increased risk of developing colorectal cancer in the future. Just waiting on the next slide. Excuse me, we're having a few technical difficulties here. Give us 1 second.
Is that the slide?
Can you pull that presentation up again? It's not on the screen.
I understand.
We're having a technical difficulty. If you would bear with us. And also don't forget to, if you have any questions, post those in the chat. And at the end, after both speakers present, we will open the floor for questions of our speakers. Bear with us, please.
Okay. So we are, for some reason, we signed out, but we are back in. So we are coming back up on the screen for readout.
Good morning again. Today's program is brought to you by the First Coast Black Nurses Association.
Can you go back 1 slide?
With sponsorship by United Healthcare.
Right there.
Yes.
Okay. Okay. Let me know when you're ready for me to start again. Okay. So then let's start here. Some polyps develop from environmental factors. So we mentioned high-fat diet low in fiber, tobacco use, excess red meat intake, excess alcohol intake, cooking meat at high temperatures, and obesity are all risk factors for polyp formation and colorectal cancer formation. Next slide. And here we have an abnormal colon with a large polyp. Next slide. Now, 90% of colorectal cancers occur in people older than 50 with no known risk factors other than age. Also, we know that people born in 1990 have twice the risk of developing colorectal cancer than people born in 1950. So we are seeing an increased incidence in older patients, and we're just not quite sure why that's the case. Next slide. Risk for developing colorectal cancer. Now, if we exclude skin cancer, colorectal cancer is the third most common cancer diagnosed in the U.S. It's the second leading cause of cancer deaths in the U.S. Lifetime risk of developing colorectal cancer is approximately 4%. Approximately 150,000 people, new cases will be diagnosed this year, 2021, but only 38% of patients are diagnosed when the cancer is localized to the bowel wall or the early stage. And why is this important? Because in the early stage, the cancer is treatable, is curable. In the early stage, the cancer is treatable, is curable. And unfortunately, in the early stage, the cancer, there will be 53,000 deaths from colorectal cancer this year due to late detection. Next slide, please. Now, who is high risk for developing colorectal cancer? We mentioned age. As we get older, our risk for developing colorectal cancer increases. Personal history, if we have a personal history of colorectal cancer, it increases our risk of reoccurrence in the future. Family history, if we have a family history of colorectal cancer, this increases our risk. Inflammatory bowel disease, such as Crohn's disease, ulcerative colitis, all carry an increased risk of colorectal cancer. Certain genetic disorders, and a history of abdominal or pelvic radiation. Next slide, please. Now, the incident rates among African-American men and women are approximately 20% higher than in white men and women, while the death rates in African-Americans is about 40% higher than in whites. Now, why is that the case? Well, it's probably a number of factors involved, but the main reason why the death rate is higher in African-American patients is likely due to late detection. Next slide. Next slide. Okay. Now, what are some of the symptoms of colorectal cancer? We may see a change in bowel habits, thin caliber stool, or new onset constipation. We may notice blood in the stool, abdominal pain, unintentional weight loss, or fatigue. But these symptoms usually occur in more advanced disease. We want to diagnose colorectal cancer in the early stages or prevent colorectal cancer altogether. And that's why the last part of this talk is the most important part. Next slide. Prevention. Next slide. The American Cancer Society recommends that people at average risk of colorectal cancer start regular screening at age 45. Next slide. And I'll just quickly go over the screening tools we have for early detection or prevention of colorectal cancer. The first one, we have the fecal occult blood test. And so this is a test where your primary care physician may send you home with a couple of cards. You place a stool smear on the card, you turn it into your physician's office, and they test that stool smear for blood. It's recommended annually with a sensitivity of 50 to 75%, and it detects microscopic blood in the stool. The downside of the test is the cancer may not be bleeding at the time the sample was taken, producing a false negative reading. And if the test is positive, a full colonoscopy is still needed. Next slide. And then we have the Cologuard test. Of course, this is a test where a box is mailed out to your house. You give a stool sample, place it in the box, you mail it back in, and it's recommended every 3 years with a sensitivity of 92%, and it detects DNA mutations associated with colorectal cancer in the stool sample. The downside is it detects cancer and less sensitive detecting the precancerous polyps that we spoke about earlier. And if positive, we'll need a full colonoscopy examination. Next slide. And then we have the virtual colonoscopy, which is recommended every 5 years. It's basically a CT image of the colon for detection of polyps or cancer. The downside is a bowel prep is needed for the procedure. And if abnormal, a full colonoscopy is needed. And there's also a small dose of radiation associated with this exam. Next slide. Then we have the flexible sigmoidoscopy examination, which is a mini or partial colonoscopy. It's recommended every 5 years. If you remember from earlier in the talk, we mentioned the colon's about 5 or 6 feet. This test only goes about 2 feet into the colon, the distal colon. So we don't visualize the entire colon, and a full colonoscopy is needed if a polyp is found on examination. Next slide. And then finally, we have the gold standard, or the colonoscopy examination, where you come in, a small IV is placed, medication is given through the IV, and basically you sleep throughout the entire exam. And once you're nice and sleepy, we take a thin scope with a light and camera on the end, have a look throughout the entire colon. If we see any polyps, they're removed at that time. A prep is given the night prior to the procedure, and usually only a light breakfast and clear liquids are recommended the day before. We have the Go Lightly prep, which is a gallon prep, which everyone's familiar with that. But we have other preps. We have a Gatorade-based prep, 3-ounce prep, pill preps. There has to be a family member or a friend there to drive. And if there is a polyp found, it's removed at that time. And this eliminates future risk of colorectal cancer developing. You're back to your normal routine the following day. And if the exam is normal, it's recommended every 10 years. That's if there's no family history of colorectal cancer or polyps found on examination. Okay. Also, if there's no other high-risk factors for colorectal cancer. Next slide, please. And this was a short video of a colonoscopy examination. But the thing I want to say is any of these screening tests that I mentioned before, although the colonoscopy examination is the gold standard, any of these screening tests that I mentioned are better than having no screening tests at all. Next slide. Now, as far as high-risk groups, if there's a family history of colorectal cancer, we recommend starting the screening process at age 40 or 10 years younger than the family member at the time of diagnosis, whichever age is earlier. In cases of inflammatory bowel disease, Crohn's disease, or ulcerative colitis, we usually start the screening process 8 to 10 years after the onset of disease. And in genetic disorders, we can start the screening process as early as age 12. The key here is in high-risk groups, the colonoscopy examination is the only screening tool that we recommend. Next slide, please. Okay. Prevention. Eat a variety of healthy foods with emphasis on plant sources, adopt a physically active lifestyle, achieve and maintain a healthy weight throughout life, and limit alcohol consumption. Next slide. An aspirin a day may be beneficial in decreasing polyp formation. Aspirin can lead to some GI upset, so you do want to talk to your physician before starting this regimen. Also calcium, and in postmenopausal women, hormone replacement may be beneficial in decreasing polyp formation. But again, you want to talk to your primary care physician before starting this regimen, especially if there's a history of breast, uterine, or ovarian cancer. Next slide. And basically, this is a chart which kind of summarizes what we mentioned earlier in early stage colon cancer. If you look on the left of that chart, there's a 90% cure rate. As the cancer becomes more advanced with regional spread, that drops to 70%. And then it's down to 12.5% with distal spread to other organs. Next slide. As far as treatment, early cancer, when it's localized to the bowel wall, surgical resection alone is curative. As it becomes more advanced with regional spread, surgical resection followed by chemotherapy and sometimes radiation. Next slide. In summary, colorectal cancer can be detected early in a curable state with the screening tests outlined earlier, but the colonoscopy exam is the only test which can prevent colorectal cancer altogether by the removal of polyps. Thank you.
Thank you, Dr. Rawls, for that very informative presentation. And remember, if you have any questions for Dr. Rawls, please jot those in the chat room, and they will be asked of him after our next speaker. At this time, I'm honored to introduce to you Ms. Gwendolyn Bryant. Mrs. Bryant's daughter, Tiffany, is the story that she's going to talk about today. Mrs. Bryant has made Tiffany's story her passion. She, her husband, her son-in-law, and her daughter have all become ambassadors to tell Tiffany's story, and they are with Fight Colorectal Cancer, a national organization that focuses on patient empowerment and advocacy in the United States. Good morning, Mrs. Bryant.
Good morning, and thank you for having me. I want to thank Dr. Neal for making this opportunity open for myself to come in and tell our daughter's story. And thank you, Dr. Ross, for all of your information. The first slide. I want to do all that I can to help someone else. Those were the words of Tiffany. We called her hashtag Tiffany Strong because of the way she went through her battle with cancer. When Tiffany first found out that she was diagnosed with this dreaded disease, she began to share her story. She put her life out there to save other lives. And this morning, I don't sit here just for conversation, but I sit here this morning for application. What you hear, take it and apply it to your life. It's important. It is the utmost urgency. If you have not had your colonoscopy done, to please have your colonoscopy done. Second, preventable, treatable, beatable. Those are some of the things that Dr. Rawls spoke about. It is preventable if you get the screening. Get the screening. It is treatable if it's caught in time. It's preventable, treatable, and beatable. The next slide, please. Age 45. If you could go back one screen. Age 45 is what the American Cancer Society say for anyone who is average risk to have your colonoscopy done at age 45. If you're at higher risk, you would have your colonoscopy done even earlier if you have a family history or if you know that you're having these types of symptoms, then go advocate for yourself and have this done. We're going to go to the next screen with the pictures. All of us know Chadwick Boseman. He died from colorectal cancer at age 43. I don't know his family history. I don't know if he had a family history, but it was 4 years that he suffered from this dreaded disease. So he had to get it somewhere in his 30s. Tiffany, age 34, no family history, no symptoms. She didn't have any symptoms until the late stages. The next slide. Younger and younger adults are getting this dreaded disease. Tiffany was 34 years old when she passed away. And now we have to look at her children. We have to pay close attention to her children, age 8, 6, and 2. It knows no age. It knows no age limit. So we have to pay very close attention to Tiffany's children. And when it's time, they are going to have to go at least 10 years sooner than when Tiffany was diagnosed. So it is vitally important to know your family history and to know that you do need to get this done. I want to stay here for a moment just to talk about who Tiffany was. A mother, 3 beautiful children whom she loved so much, a daughter, sister, a wife. Could you please just leave that particular slide up? I want people to see who Tiffany Ortiz is. Tiffany was diagnosed at age 32. I remember her calling myself and her dad and told us that she had to go to the emergency room because she was bleeding. She was having rectal bleeding. When we got to the emergency room, we sat briefly in the emergency waiting room with her, and we began to pray with her and we talked to her. And when she went back for the examination in the emergency room, after the examination, she came out and she said, "Mom and Dad, they said that it's hemorrhoids." But Tiffany, being a nurse, being in the position that she was, she knew that it was more than just hemorrhoids. Tiffany was a nurse in the mother-baby unit at UF Health. She loved what she did. She loved it so much until she worked up until January before she passed away in March of last year. Tiffany was pregnant at the time. So that's why the doctors may assume that it was just hemorrhoids because of her pregnancy and the rectal bleeding. Well, they told her after she would deliver her baby to have a colonoscopy done. So after Janessa was delivered, Tiffany went in and she had a colonoscopy done. And words that you never want to hear. Tiffany and Jonathan heard these words: "You have colon cancer." Not just colon cancer, you have stage 4 colon cancer. She was diagnosed in the late stages. Sometimes there are no symptoms at all. When Tiffany went back to her doctor, they scheduled surgery for her to remove the tumor out of her colon, and they found out that it had spread to her liver. It had metastasized to her liver. She had the surgery done in November. I'm sorry, she had the surgery done in December And in January, she began her treatment, chemotherapy treatment. She went through a series of treatments because for some reason, God only knows why, she started out with the 5FU pump. If some of you are familiar with that, she started out with that. She would go in a couple of days a week, and she would stay 3 to 4 hours for treatment. And then she would come home with the pump, which continuously gave her that treatment. And then we would go back in and they would take the pump. And then until, the cycle just ran, over and over. She ended up, we don't know what happened, she ended up, her mental status started to change from this chemotherapy. So they had to end up putting her on a different type of chemotherapy. She went through a series of chemo treatments. And one day we had to rush her to the emergency room again, but we found out she was having right pain in her right side, excruciating pain. We got to the emergency room, they did the CT scans, and then they come in and they tell us that it's her gallbladder. It had spread to her gallbladder, but not only her gallbladder, her lungs. It had spread to her lungs. So I can't express it enough to please get your colonoscopies done. Tiffany put, like I said in the beginning, she put her life out there to save other lives. And that's why I sit here today, not in my own strength, but by the strength that God gives me to share her story, because this is what she wanted to do. She wanted to help others. And that's why our family will not stop until we get something done. Age change, 45, for me, it doesn't work for me. I know what the American Cancer Society, I know what the CDC said, I know what everyone is saying. But with so many young adults getting this, and then her children are coming up, what do we do? What can be done? After we found out that she had, it had spread to her lungs and everything, they put her on another treatment. And Tiffany ended up going back in the hospital in March of last year. And she went back in because there was a bowel blockage. So they had to go in, they had to put in a stent, and then come to find out that that wasn't working for her either. So she stayed in the hospital for about a week. But all during this time, if you knew my daughter, she was always an encourager. She always tried to help others. And even in her hospital bed, she's calling to check on another friend to see how her friend is doing. That's just the type of person she was. And that's why we call her our hero. Tiffany went through her journey. She didn't complain about, woe, it's me. She did not complain. She went through her journey with such strong faith, And that's why I can sit here today and I can tell her story. Yes, it's very painful because we don't have our Tiffany with us physically here anymore. But she has changed so many lives, even though her life was taken. I've had so many, I had some nurses even message me and telling me that they got the colonoscopy done because of hearing Tiffany's story, and whatever we can do for you all, just let us know. So I thank God Tiffany's story and whatever we can do. So I thank God that He is allowing us open doors and opportunities to spread the word, and especially in the Black community. We perish for lack of knowledge. If we don't know and don't understand, we need more education in our African American communities. Like Dr. Worrell says, 20% higher risk in our African American community. 40% is likely to die. Our Tiffany was in the 40%. But we truly thank God for her 34 years that He gave us. And I thank you for taking this time to listen to Tiffany's story. And thank you.
Wow, Mrs. Bryant, that was a very, very powerful presentation. I'm sure most of you can imagine a mother's pain as she talks about her daughter's battle with colorectal cancer. Dr. Rawls, you talked a lot, and I know that some folks may have just chimed in. So I'd like to go over some of the things, if you will, with both of you, and start asking a few questions. So, Dr. Rawls, what should a person do to lower their risk?
Well, certain things we can do, certain things we can control. Our diet, for sure. We want to decrease the amount of red meat in the diet. This includes lamb and also pork. We want to decrease the amount of processed foods, hot dogs, sandwich meat. We want to increase the fiber in the diet. I mentioned at least 25 to 30 grams of fiber a day. This number probably should be even higher. Fresh fruits and vegetables. If we smoke, we want to stop that for sure. We want to limit alcohol consumption. You know, folks who are moderate to heavy drinkers, say 50 grams of alcohol a day, which is about 3 to 3.5 drinks a day, have a 50% increased risk of colorectal cancer. Those are things we can control. Also, we want to maintain a healthy weight throughout life. Exercise, you know, that makes a difference. So those are things that we can control. Genetics, not as much, but those are things that can make a difference, that we can control.
Thank you. And Mrs. Bryant, I know you talked a lot about Tiffany. You mentioned that the American Cancer Society only recommends the age of that was older than what Tiffany, when Tiffany was diagnosed. But did Tiffany ever share at all, you know, Mom, I think I was having symptoms long ago and I just didn't know that that's what it was? Or did she just not ever have, you know, the more you all learned about it, can you talk about or think about any symptoms she may have had?
Actually, no, ma'am. She did not have any symptoms at all, not until her third child. She had her first child, no symptoms, no hemorrhoids, no anything. Her second child, same thing. The third child was when her symptoms began, and that was the rectal bleeding. And that's when she was told to, after she delivered the child, to get the colonoscopy. So no prior, nothing prior.
Thank you. And I hope our audience is paying attention to that. When it comes to cancer, unfortunately, you don't find out with certain cancers until, as Dr. Rawls mentioned earlier, and then as Ms. Bryant just said, until the cancer has progressed. So Dr. Rawls, you know, when you know, all of us are told it's time for our colonoscopy, you know, we get like, oh no, you know, is that the only exam that I can have in order to detect colorectal cancer? So is it, Dr. Rawls, that dreaded colonoscopy is the only way that you can detect colorectal cancer?
First of all, the colonoscopy is not that bad. But to answer your question, yeah, there are a number of exams that are approved for colorectal cancer detection. We mentioned the fecal occult blood tests, the Cologuard test, all stool-based tests. We have the virtual colonoscopy, which is basically a CT scan, which can detect polyps or cancerous lesions. So all those tests are approved. But I must say the colonoscopy is the gold standard because not only do you detect cancer, but you can prevent cancer. So we can remove those precancerous lesions, the polyps that we discussed earlier during the exam, and this eliminates future risk of cancer. The other exams really don't do that. And as far as the colonoscopy, I know the worst part is the prep, and we do have different preps available now, some with less volume. But once you get through the prep, I mean, it's really a pretty easy exam. You come in, small IV is placed, medications given through the IV, and you're sedated for the entire exam. And some of my patients have said it's some of the best sleep they've ever had. And once you're nice and sleepy, we take the thin scope with the light and camera, have a look throughout the entire colon. And if any polyps are found, they're removed at that time, and that eliminates future risk of colorectal cancer. So the colonoscopy is still the gold standard.
So when you find polyps during the colonoscopy, what advice do you share with your patients after that, obviously in order to minimize having polyps on the next exam?
Yep. So we give them a handout. We go over those dietary modifications, how they can increase the fiber in the diet, how they should decrease the amount of red meat in the diet. We talk about exercise, maintaining a healthy weight. If they're smokers, we stress the importance of stopping smoking at the time. So those are all things that we talk about that may help decrease the risk of polyps in the future.
Thank you. And Ms. Bryant, I know you said that you all, Tiffany has 3 children that she left behind, and obviously, and you also mentioned that she was a twin. Have
Yes,
you or any of your family members, talked about or made any of those changes in your lifestyle, not knowing now that you have a family history of colon cancer?
Oh, yes, ma'am, definitely. All of us, including her twin sister, her brother, her older brother, my husband, and myself, Tiffany's husband, my daughter-in-law, we've all gone in to have our colonoscopies done. And as far as lifestyle changes, yes, we have. We're exercising more. I know my husband and I, we're exercising a little bit more. We've changed our diets, and those are the things that we have changed. Yes, ma'am.
Now, I don't know, folks, as you're listening, you can hear the passion in Mrs. Bryant's voice. She doesn't know this, but I read the letter that she wrote to Dr. Carol Neal asking if could the Black Nurses Association and Ms. Bryant work together to get this program to you all today. And so, folks, if you're listening, think about your own family and your own lifestyle changes or habits that you have, or choices, I should say, that you have that you need to make. Ms. Bryant, I don't want to get you upset this morning, but I just wanted folks to understand your passion and your family's passion. We met with Ms. Bryant and her husband the other night, and one thing that he mentioned, which was so heartwarming, is, a mother having to deal with this and live through this experience. So that's why we're having this program today. Dr. Rawls, I want to follow up. What's the difference between the fecal immunochemical test, the Hemoccult, Cologuard, and colonoscopy for screening colon cancer?
Okay, so the Hemoccult is basically the stool-based test, and it checks for blood in the stool, really hemoglobin, so human blood. So it's pretty specific for human blood. And that sensitivity is somewhere between 50 and 75%. The Cologuard test actually checks for the same blood along with cancerous DNA cells. So it tests for blood and possibly cancer cells. And so that sensitivity is 92%. And the colonoscopy examination actually visualizes the entire colon. And so if there are polyps there or colon mass, we can remove polyps, take biopsies, whatever we need to do at that time. So the colonoscopy examination is the gold standard because it cannot only diagnose colorectal cancer, but it can prevent it altogether.
And those, you mentioned the Cologuard test. I know I've seen the commercials advertised on television. It's not meant to be the only way that people would detect whether or not they may be at risk for colon cancer, is it?
No, not at all. Not at all. First, it's only recommended in patients who are average risk. So if there's a family history of colorectal cancer or any of those diseases that would predispose you to colorectal cancer, we mentioned inflammatory bowel disease, Crohn's disease, or ulcerative colitis, they wouldn't be a candidate for that Cologuard test. So I think it has its place. You may have some patients who, for some reason, they don't want to have a colonoscopy, or for some reason they can't tolerate the prep. So any of those screening tests that we mentioned are better than having no screening at all. Yeah.
So during your presentation, Dr. Rawls, you mentioned that folks that were born in 1990 have as great a risk as persons who are over the age of 50. Why is that?
And yes, higher risk. We're not 100% sure why that's the case. I think part of it is diet. I think that's probably a big part with all the processed foods that are available now. But we're not 100% sure why that's the case.
So thank you, Dr. Rawls. So Ms. Bryant, what would you say to someone who is afraid of getting screened?
Don't be. It could be a matter of your life or death. And I would not want any family, to have to go through and experience what we've experienced and how we found out with Tiffany at such an early age. It's really not a bad prep at all. It really isn't. Once you get the prep, you're halfway there. Once you get into the office, they will sedate you. You go to sleep, like Dr. Rawls say, that was one of the best sleeps that you could ever have. And before you know it, you wake up and it's all done. I would rather know than not know.
That's true. And again, if for those of you who may just be chiming in, because I know this program is being broadcast live on Facebook, Mrs. Bryant shared the story of her daughter, Tiffany, who died last year at age 34, folks. We talked about Chadwick Boseman, and of course, we definitely grieve with his family because most of us saw the Black Panther, and Mr. Boseman was in his early 40s, but had been diagnosed in his 30s. Mrs. Bryant's daughter, Tiffany, was diagnosed at age 32. Just think about most of us at the tender age of 32, we consider that the prime of our life. We're not thinking about our health. I think the message that I hope you all get today is the importance of knowing your family history, the importance of going to the doctor on a regular basis, As Dr. Rawls talked about, the importance of eating a healthy lifestyle, exercising regularly, limiting alcohol consumption, understanding your body. You know, these are conversations as young people, persons who were in their 30s, like Tiffany. And Tiffany was a nurse, by the way. So it's not as though that she was, just, did not understand what was going on with her. So she was a nurse. So just imagine hearing Tiffany going through that. But the one thing that Miss Bryant said early on, she never stopped her passion for sharing with others, telling her story. Who usually when people are diagnosed, they don't want people to know what they're going through, but she told her story. So Dr. Rawls, I wanted to ask if someone has been diagnosed with cancer in other parts of their body, are they at an increased risk of developing colon cancer?
Yes, certain cancers are associated with colon cancer, cancer of the small intestines, stomach cancer, breast cancer, ovarian cancer. It carries a similar genetic. There is a link there, for sure.
And so when you talked about the other cancers and whatever, and I want to get back to diet a moment, because this past year has been a year like no other, obviously for the Bryant family and Ortiz family as far as Tiffany is concerned. But oftentimes people will say because of limited resources, they are unable to eat fresh fruits and vegetables. Dr. Rawls, what would you say to them? I know there are a lot of conversations about the difference between eating fresh vegetables and fruits versus canned fresh vegetables and fruits. What would you tell folks about that?
Yeah, I would just stress we can just try to do the best that we can. I know is difficult. I know organic foods are 5-10 times more expensive for sure, but we do know, or I suspect there is a link there between processed foods and a higher risk of colon cancer. So we just try to do the best that we can when it comes to diet,
Thank you. And again, I just wanted to point out some things that Dr. Rawls said throughout his presentation. If you're just logging on, if you were born in the year of 1990, you have a greater risk of developing colon cancer than persons over the age of 50. If you're 50 and over, other than age, age is the one risk factor that puts you at risk. However, it's important that we know our family history of colon cancer, and it's also important that we engage in physical activity. So when your friends ask you to come on and let's go for a walk, just get that extra energy. And I often share my story that I had my knees replaced, Dr. Rawls, and it was at that moment in my life that it changed. I mean, anybody who knows me knows that it was at that point in my life that I knew that I was able to exercise on a regular basis. So, a lot of us live in Florida. The weather is getting wonderful right now. I think it's important that we, get with our family, get with our friends, rather than going out to get something to eat with your friends. Once we all get our vaccine for the COVID vaccine, we're wanting to get together with friends and family. I think that it's an opportunity for us to now, after listening to today's presentation on the importance of our diet, on the importance of maintaining a healthy weight, the importance of exercising regularly, I think what we should start, Dr. Rawls and Mrs. Bryant, is a movement of getting active and getting healthy while also knowing your family's risk. Some of you, and I should ask, actually both of you, have you ever talked to family members that when you are doing your family tree, you know, when folks are preparing for their family reunion, they want to do their family tree. Have you ever talked to folks about adding your family's health history to the family tree? Good idea, huh?
It
Very
is.
good idea.
Yes.
Yeah, because, you know, I think Miss Bryan, and correct me if I'm wrong, you mentioned that you had no previous history in your family of colon cancer. Is that right?
That is correct. And none on my husband's side either. No one.
So that means Tiffany, being a young woman, age 32, folks, and remember, she started having initial symptoms during her third pregnancy. So it's so important that from today's story, from hearing Tiffany's story, that you understand that it's not just older persons who get colon cancer. Dr. Rawls, I'm going to first start with you as we end near the end of our program, to ask if you would just summarize the key points of today's lessons so that people will understand more about colorectal cancer.
Well, I think just stressing a few points, definitely know your family history, get screened when it's time for that screening process. A colonoscopy is a gold standard, but any of those tests are better than having no tests at all. We mentioned diet, you know, avoid or limit red meat intake, avoid processed foods, more fruits and vegetables. And one thing that you said, Mrs. Turner, you know your body better than any physician or anyone else. And so if you start noticing changes there, then please talk to your physician about that, and don't stop until you get an answer.
Thank you. Mrs. Bryant, what are your final thoughts? What would you like to say to our audience today? If maybe something else about Tiffany, or just as you have given your life now to educating others, becoming that ambassador telling Tiffany's story.
Yes, ma'am. Her cancer actually started when the doctor, I just want to say this at the end, the doctor, when she had her surgery done to remove the tumor from her colon, he said it had been growing since she was in her 20s, maybe about 26, 27 years old. So pay attention to your bodies. If you're having any type of symptoms that are not normal for you, like it has been said, you know your own body. So you have to advocate for yourself. If one doctor says this is what it is, and you still feel, I don't think so, go to the next doctor. Go until you find an answer. And please, I cannot stress enough, please, if you're of that age, if you have family history, please get screened. We can no longer be silent about a silent killer anymore.
Thank you, Dr. Rawls. Thank you, Mrs. Bryant. And I'd also like to thank Dr. Zamekio Jackson and his team for putting on an excellent broadcast here today. And I would like to remind those of you who are requesting continuing education units to complete your evaluation form. And I'd like to thank United Healthcare for sponsoring today's program, and thank the First Coast Black Nurses Association for continuing to educate our community about issues of importance to the Black community and the entire community about taking better care of your health. Thank you to the Northeast Florida Medical Society, and that concludes today's program.
I don't know if we're still on camera or not.
You did a fantastic job.
Thank you. You did too. Thank you, doctor.
Absolutely.